Hello, everyone. So I'm going to talk about quality metrics for radiation planning in breast cancer. I'm not going to cover all the metrics, but I will try to discuss some of the common findings I have noticed through workshops and peer review, and I'll try to address those issues and give us what we do in our own practice. Now, these quality metrics which I'm talking about would be relevant to whole breast with sequential boost, whole breast with SIV boost, whole breast with regional nodal radiation therapy, or chest wall with regional nodal radiation therapy. So it is relevant to each one of these clinical scenarios. I would not cover partial breast radiation therapy. And again, I'm not going to talk about technique. Technique could be 3D conformal radiation therapy with field within the field, VMAT, IMRT, or rapid arc dynamics. Some of the quality metrics are more relevant to VMAT, IMRT, or rapid arc dynamics, but irrespective, they could be used for any technique. And in our own practice, for all left-sided breast cancer and all patients who get regional node, irrespective of left or right, get DIBH to decrease dose to heart and also to decrease the dose to the lung. And the reason why the lung becomes important is because many of these patients now get TDM1, Pembro as part of neoadjuvant and adjuvant treatment. They all can cause pneumonitis, and we want to reduce the risk in whatever way we can. Now for deep inspiration breath hold, now we favor surface guidance because it has got voluntary feedback. The setup is faster and easier and more patient-friendly approach. And you can see why DIBH helps out. You can see the lung volume is increased and the separation between heart and lung has increased. So you can decrease the heart dose and also decrease the lung dose. And both are important in breast cancer patients where we are treating for definitive intent. So the metrics I'm going to cover is some of the metrics about coverage and OAR, not all of them, only some of them, and some aspect of dose homogeneity, which is important, more important in the era of hypofractionation. So before we talk about conformity, I want to highlight the nodal contouring. So the two major atlases for nodal contouring is RTOG nodal contouring and EORTC nodal contouring. There are major differences. One is craniocaudal difference, the other is mediolateral difference. So craniocaudally, RTOG extends from cricoid to the junction of brachiocephalic and subclavian. You can see that. But importantly, medially, it covers both IJ and common carotid. So you can see your CTV comes very close to esophagus. So when you do PTV expansion with RTOG atlas, irrespective of the technique you're using, I don't do any medial expansion because medial expansion would increase the dose to esophagus, which is not acceptable and desirable. And that being said, yes, you will underdose part of the medial part of the supraclavian, but we have done it all along when we use 3D technique, when you use conformal block to block the esophagus. Now, in contrast, the EORTC volumes are much more smaller, both craniocaudally and medially. Craniocaudally, it is only 5 millimeter above and below the subclavian, you can see. So it not only decreases its dose to esophagus, it also decreases dose to thyroid gland. And you can see medially, it excludes common carotid, and that's based on the recurrence pattern that the recurrence rate around carotid is very low, and you don't need to include that routinely. The Danish group published their outcome data using this approach, showing the recurrence rate outside this small regional volume is very limited. So I think there is some validation, and some people use EORTC guideline for intermediate risk and RTOG for high risk. That's up to the institution to decide. But I just want to highlight that when you do EORTC, you're much less medial, so you are sparing a lot more esophagus. But when you're using RTOG, you're a lot more medial, so you need to be careful in your PTV expansion. The second aspect of conformity is the chest wall. And again, RTOG and EORTC have significant difference. The RTOG atlas, you can see it includes intercostal muscle and ribs, while the EORTC is excluding even pec muscle because most of the recurrences occur in front of the pec muscle. So one is treating only the volume in front of the pec muscle, the other is treating even pec major, pec minor, intercostal muscle and ribs. And there has to be some adjustment or compromise between the two. So we did some review and wrote one letter to the editor in their journal looking at recurrence pattern. And like EORTC, the majority of recurrences were in skin and subcutaneous tissue. But there were about 15 to 30% recurrences which were seen in between pec muscle or involving pec muscle. There was no recurrence rate in intercostal muscle ribs. So we suggested that the RTG atlas is a bit too much. And when you try to cover that big volume, you end up treating more heart and more lung, which is again not desirable because each grade to the heart matters. And when the URTC atlas came out, we again said that probably it is a bit too skimpy and we need to probably include pec muscle also. So there is opportunity in our own practice. We include pec muscle, pec major, pec minor, skin and subcutaneous tissue. Some people only follow URTC and only include skin and subcutaneous tissue, but I feel RTG atlas is a lot more larger and probably the recurrence pattern doesn't support that unless it's an inflammatory breast cancer, which is not what we are talking about. So again, talking about the chest wall contouring. So we talked about that before we talk about conformity. The contouring of supraclavian is important because the dose to esophagus would matter and how you expand would matter. And contouring of chest wall is important because then again dose to heart and lung would matter. So it's important that you standardize this in a practice so that everybody is consistent in your treating increased or decreased volume from inter-patient individual variations. So the conformity part, which I'll cover, is the goal of the conformity to improve coverage and to reduce doses to OAR, which in my mind, which I'm going to talk about, the heart, LAD, and esophagus. And the reason of this talk is more about esophagus. In 3D era, esophagus was not a factor because our gantry angle and the conformal blocked esophagus. But when we switched to IMRT and VMAT, esophagus doses were not defined well. Even if you look at the Alliance protocol or the NRG protocol, when they allow VMAT or IMRT, they don't talk about esophagus constraint. So I'll discuss some of it in detail. We know that each grade to the heart matters. So we try to keep the mean heart dose to less than 1 gray for early stage breast cancer and less than 2 gray for regional node radiation therapy. Unless IMN is involved, then it can go up. There is some studies about LAD being important for coronary artery disease. There is one paper from Beaumont in Red Journal. We talked about LAD maximal equivalent dose of 6.7 gray. So when we put the heart constraint, we put both mean heart dose constraint. We also contour the LAD and keep the maximal LAD dose to 6 or 7 gray. Try to avoid any beam going through LAD or heart when you're using 3D conforming technique. And the ways to reduce the heart dose could be with modern Foden technique. Could be, as I said, DIBH is important. You could do prone positioning for early stage breast cancer, and along with your whatever technique you use, you need to have a conformal heart block. And sometimes VMAT can help you out if the chest wall is plastered to the heart. That can help you out. But the goal is to keep mean heart dose within 1 or 2 gray if possible, and LAD dose maximal within 6 or 7 gray dose. Now the esophagus constraint became important because doing many workshops across the globe, I found that many people routinely contour the entire esophagus because even the auto segmentation did that, and that's what most of the outcome data for thoracic malignancies. Like for lung cancer, we use a mean dose of 30 to 35 gray, and they would put the same constraint for breast, and the dose would be very low, and we would be happy. But we need to understand that our threshold for accepting grade 2 or 3 esophagitis for breast is much lower than say for lung cancer, where we expect that to be the case. So if we are not careful, we end up giving more hard esophageal dose. And there are many studies which have shown with IMRT and VMAT compared to 3D, the dose to esophagus is high. So in 2 recent studies, they defined the denominator as upper esophagus. Like in one study from OSU, they define the esophagus from cricoid to bifurcation of trachea. And the other one from cricoid to aortic arch, very much similar. And they try to keep mean esophageal dose less than 11 gray and limiting V20 to less than 15%, which significantly helped reduce the risk of esophagitis. But this is only for upper esophagus. Similarly, in the Wong et al. Study, which was for hyperfractionation, in contrast to Yanni, which was for conventional fractionation, again showed that keeping V25 less than 20% significantly decreased the risk of esophagitis. So these are important numbers, both in terms of dose constraint and also in terms of defining the denominator, because these are the 2 common practice pattern I noticed where people contour the entire esophagus, aim for a different mean esophageal dose, and I'll show you some examples of that. Like this is in one of the workshop I did, I found this error. So we asked that practice to go back and look at their esophageal dose with standard contouring, where entire esophagus from cricoid to G junction is contoured, which includes both red and blue. then asked them to contour the upper esophagus from cricoid to carina, and they were not using any hard constraint for the esophagus because that was not, it's not part of in most of the published protocols. Then they replanned the patient with esophageal constraint for upper esophagus. You can see with standard contouring, the mean esophageal dose was 5.5 grays. They felt good about it. But as soon as you modify the contouring, the dose went up by 3 times, which is well above the threshold from Yang et al., where the threshold is about 10 gray or 11 gray. So you can see just by modifying the esophageal contour and constraining the esophageal dose came down significantly. Similarly, the V10 went down from 43% to 32%, V20 from 35 to 23, and V30 from 26 to 15. So you can see all the numbers went down by putting esophageal constraint. And you can also see the standard contouring was underestimating the true risk of esophagitis because it was contouring the entire esophagus. So by doing this exercise, they have changed their practice now, and they contoured upper esophagus and put the constraint for the upper esophagus, which is important because that's what would correspond to the risk of esophagitis. And they also looked at the coverage. So they looked at the coverage without putting esophageal constraint and with putting esophageal constraint. They did lose about 2 or 3% coverage of the supraclav, but the overall coverage was still within the acceptable numbers, around 95% or so. So yes, the coverage loss was not clinically significant, but the dose to the esophagus did reach significant number. And it's important that when you define clinical goals in your practice for esophagus, you need to define upper esophagus. That's one thing. When many of us use auto-segmentation, which draws the entire esophagus, we need to train our dosimetrists to define upper esophagus and put a constraint based on the upper esophagus for both maximal dose, V20, and mean dose. Like you can see, that's showing the 20 gray color wash. Just by putting the esophageal constraint, you are able to restrict it. And there is no PTV expansion medial, which helps out. The second metrics I'm going to talk about is dose homogeneity. So dose homogeneity is again not like commonly practiced, even though there is more and more data on dose homogeneity. The hypofractionation, the newer hypofractionation studies have included that. There are different ways to define it. So I will try to summarize and explain how we do things for dose homogeneity, because dose homogeneity does predict the risk of skin toxicity. Like the initial studies of 2D versus 3D or IMRT. When I say IMRT, this was mainly field within the field. You can see what they noticed, that the maximal dose went down by using field within the field, and like in the Dutch study, the V110 went down from 1.5 to 0.5%. And similarly in the Donovan study, you can see the comparing 2D to 3D field within the field, the 1% of the total breast volume receiving 105 went down from 92 to 19%. The 110 went down, the 105 went down. So all of the numbers, like for dose homogeneity, including the 105, the 110, and the volume of breast getting 105 or 110 went down, which was important, and it did lead to less discommission and less breast pain, which is important endpoints for the patients. Now the fast forward study, which with the 10 years follow-up showed non-inferiority to hypofractionation. They were very stringent in terms of dose homogeneity. They defined V105 to be less than 5%, V107 to be less than 2%, and breast Dmax to be less than 110. And when we do fast forward, we do follow that thing. We did one of the largest study, about 500 patients, for patients with moderate to large breast size, like breast size more than 100, more than 1,000 cc or so with hypofractionation. Majority got field within the field, but a percentage got IMRT, tangential beam IMRT, not VMAT, not the VMAT technique, but more tangential beam IMRT. We came up with our own institutional guideline about 10 years ago, using V105 less than 10 to 15% and V110 to be 0. And we collected the data across the entire network, and we did find that V105 less than 10% predict the risk of grade 3 discommission, acute toxicity. So our median 105 was 9.7, median 107 was 0.8, and median 110 was 0. But we did find that larger BMI elderly, and V105 less than 10% predicted for skin toxicity. So again, showing dose homogeneity matters. When Astro came up with the guideline in 2018, they said try to keep V105 as low as possible, but in the appendix they mentioned less than 200 cc, which in my mind is a bit higher number, because if you have a 1000 cc breast, 200 cc could be 20%. So recently at Astro this year, Mount Sinai group looked at Astro guideline and their outcome data. So they practiced V107 less than 2% and V105 less than 200 cc. And they found that V105 less than 50 cc corresponded to the risk of breast pain. And so it was a significant factor in having acute breast pain. So they also noticed that the V105 predicts for acute skin toxicity during OTB, and not, the 200 cc was a high number. Their absolute number was less than 50 cc or less than 5%. So again, you can see a consistent theme that V105, whether it is 5% in fast forward, 10% in our data set with hypofractionation, or this recent Mount Sinai study showing 50 cc or less than 5%, showing the risk of desquamation, risk of breast pain, and risk of acute skin toxicity. So dose homogeneity matters. And one of the reasons why hypofractionation has been doing is showing non-inferiority. Yes, fractionation has an effect, but dose delivery, a better dose delivery has been an important factor, because dose homogeneity has improved with the modern technique. We also not only look for V105 number, we also look for the location. So we try not to have V105 in the inframammary fold, in areolar region, or a big contiguous area underneath the dermis. So we try to push it bone posterior. We try not to have it in inframammary fold or areolar region, because these are sensitive area and they do increase the risk of skin toxicity. So we also look for the location of V105, avoid in nipple and areolar and iron fold, and avoid a big contiguous area underneath the skin. Just to show you an example, what we try to avoid, and try to have this area having no V105. Now the other thing which has come up is SIB boost, and in SIB boost, to define dose homogeneity become a bit tricky, because you are giving 48 gray to part of the volume. So Import High did in a very different way. They defined 3 volumes: highest risk, high risk, and low risk. Highest risk was surgical bed with 5 mm margin, which they prescribed 48 gray. The intermediate risk was like partial breast volume, which was like 15 mm expansion to create a partial breast volume plus PTV, and that they prescribed 40 gray. And the low risk volume was the whole breast, which they prescribed 36 gray. And I think part of the reason why they came up with this thing was to avoid heterogeneity or dose inhomogeneity. So 36 gray to the whole breast, 40 gray to the high risk partial breast, and 48 gray to the boost volume. And their boost volume of surgical bed plus 5 mm is much smaller than the RTOG. At the same time, the RTOG SIB study did not define any dose homogeneity. But this protocol did define. They said whole breast minus partial breast, so the part of the breast tissue outside a partial breast volume, they said 40 gray to less than 5%. So very stringent dose homogeneity. And they also said in the boost volume, V107 should be less than 3%, and the maximal dose should be less than 110. So the hotspot should be limited to the surgical bed, but again, they defined what should the number be. And outside the partial breast, the dose homogeneity was to be maintained. So this is what I'm saying. This is the highest risk, which got 48 gray. This is the intermediate risk or high risk, which is a partial breast, which got 40 gray. And this yellow volume is what they give 36 gray. And if you look at it, they accepted median dose of 36 gray to this yellow volume, median dose of 40 gray to this orange volume, and median dose of 48 gray to this highest risk volume. And they defined like less than 3% of the volume should receive greater than 51.4 gray, and global maximum 52.8, which I showed. So they were very stringent with dose homogeneity in terms of where to have the hotspot and how to define the coverage for different risk volume. So what we do is you could easily do the way Import High has done it. What we do is we try to make the process a bit simple. What we do is we define surgical bed with 5 mm margin as the 48 gray volume, and the rest of the breast we give 40 gray and 15 fraction. So you can see this is the dose cloud of 40 gray. And we usually we get 95-95, but we accept 90-90 also to achieve dose homogeneity. This is a 35 gray, which was what import high accepted as a median dose. But we try, our median dose is usually close to 40 gray, but this is also acceptable. And then you can see the V105, like, and we talk about 105 or 40 gray. So 42 gray line outside the boost volume is very low. You can see only tiny descent. And we try to limit that to less than 5 to 10%. And the 48 gray is limited to the surgical bed with the hotspot inside it. So you can see there are various ways of doing it. We try to do it this way, where we have whole breast getting 40 gray in 15 fraction, the boost volume, which is surgical bed with the margin, getting 48 gray in 15 fraction. We try to give 40 gray to the whole breast, but try to limit 42 gray, which is 105% of 40 gray, to less than 5 to 10% of the area outside the surgical bed. And the hotspot, which is 107 and is limited inside the surgical bed, and 110 is 0. And we are able to achieve that. And we have that in our clinical goal. And I'll show you the example of that. So this is what we follow for dose homogeneity. For whole breast irradiation with moderate hypofractionation, we try to have V105 less than 10%, V107 less than 2%, and a D maximum of less than 110. We avoid any clustered hotspots in inframammary fold, nipple areolar complex, and subdermal plates, which I showed you the example. For ultra hypofractionation or 26 and 5 like fast forward, we are much more stringent based on the study. We try to have V105 less than 5%, V107 less than 2%, and again, maximal dose less than 107 to 110. To achieve this, we all know we aim for 95-95 coverage, but we can accept 90-90 coverage as long as the area at highest risk, the surgical bed, if the margin is covered adequately. So you always contour that and try to make sure dose distribution is acceptable. For simultaneous integrated boost, I showed you there is various ways of doing it. You can aim for 95-95, so you can aim for 40 gray to like 95% of the volume to get 95% of 40 gray for the whole breast. But you can accept 90-90 to protect dose homogeneity and OAR. We strictly limit the high dose spillage. I showed you the example, like 42 gray or 105 less than 5 to 10% outside the boost volume, which is surgical bed with 5 millimeter margin. And inside the surgical bed, we make sure that surgical bed for V95 is 95 and above, which is 48 gray. V107 is less than 3%, and D max is less than 110. And we try to limit hotspot within the confine of the tumor bed volume, preferably posteriorly rather than anteriorly because of the skin and dermis. So this is what we follow for moderate hyperfractionation, ultra hyperfractionation, SIB boost to achieve dose homogeneity. And this is an example, like you can see that in none of the NSCPP constraint, these esophagus was there. We added esophagus maximal dose 25 to 30 gray, mean dose less than 10 gray for upper esophagus from cricoid to tracheal bifurcation. LED maximal dose of 600 centigrade, but we accept up to 700 centigrade. And for dose homogeneity, V110 0 and V105 less than 10%. And when we look at this, we look at composite plan. So if we are treating 3D conformal technique with breast and supraclav with like a single isocenter technique, we look at composite plan to look at the coverage as well as the hotspots, not individual plan. If you do VMAT, then it doesn't matter because there is only one plan. So it's important that the contribution from each field is accounted for when you're looking at the plan. The coverage part is very similar for the like any other protocol, but as I mentioned that we do accept lower coverage to achieve dose homogeneity. And I show you an example of SIB boost. So this is how we define this. We have, see, this is one case we talked about. Maximal esophagus dose is 30 gray. The mean dose is 9.10 gray. And we define the breast minus boost volume. You can see the coverage is still 95-95, although I would accept 90-90 also to get dose homogeneity. That V105 is 8%. And V107 is 3.4%. So you can see that we add that as a constraint. So our planner are trying to achieve that. And based on clinical call, you can always scale down the coverage to achieve those dose constraints. It's important that we maintain dose homogeneity. And also you can see the esophagus constraint are also added to the plan. So in conclusion, both conformity and homogeneity important for avoiding unnecessary doses to heart, lung, and esophagus. The contouring of supraclav area and chest wall is very important. We need to be consistent and not over contour or under contour to avoid coverage issue, but more importantly, increase dose to heart, lung, and esophagus. In the modern era, when VMAT and IMRT is being used more often, esophagus needs to be constrained with appropriate denominator of upper esophagus, which I showed you the example. Both heart and LAD important to follow ALARA principle. And as I mentioned, focus on dose homogeneity important over aiming 95 for the whole breast volume. And for SIB boost, focus on high risk. A tumor bed boost helps you to avoid the dose inhomogeneity. So these are important principles to be practiced, which will help us improve the quality of the plan. And we do follow this in our own practice, and have noticed in many practices across the globe through peer review and workshop that the lack of consistency in dose homogeneity, contouring of chest wall and supraclav, and dose to the heart and LAD. So this was the idea of having this brought up for the discussion, and hopefully this will help your practices with some of the practical guidelines which we discussed. I want to thank Dr. Kaushal Majumdar, who did the esophagus study for me after the workshop, Dr. Manjinder Sandhu, who also implemented this in the network and showed significant reduction in esophagitis, but just by changing the dose constraint and denominator. Fady, who's my resident at AHN Pittsburgh, he created the table and he's writing a review article on dose homogeneity. Watch out for that. Priyanka Agarwal is my physicist who shared the plans which I showed for SIB boost, and Colin Champ is my colleague who, along with Fady, are working on dose homogeneity review article. Thank you for listening. Thanks a lot.